Good afternoon, ladies and gentlemen. Thank you very much for coming to this session on surpassing barriers with tirzepatide. Now, Dr. Shukla has made my job really easy because he's told you how this works. Now, my job now is to tell you the extent to which it works. And I'll tell you something, it works. So, with that in mind, this is a disclaimer and this is my disclosures. Uh, Tirzepatide is indicated as an adjunct to diet and exercise. All drugs in diabetes are used as an adjunct to diet and exercise for type 2 diabetes. It is also used for the treatment of obesity. Obesity, we must recognize, is a disease, and in people who have an elevated BMI, we have to consider putting them onto weight losing drugs. Tirzepatide ticks the box on those accounts. And we know from the ADA EASD algorithm that 5 to 10% of weight loss leads to metabolic improvement, while 10 to 15% of weight loss can improve things like heart disease, heart failure, OSA, MAFLD, and multiple other disease conditions. So people with type 2 diabetes must be treated aggressively with tirzepatide or drugs like this to provide better outcomes in patients who have diabetes. So I will be talking today about the diabetes side of trials. There are two sets of trials which have been conducted with tirzepatide. The SURPASS trial is with diabetes. The SURMOUNT trial is with obesity. An easy way to remember which one is which is obesity contains a O, so the SURMOUNT trial is in obesity. So this is how I try and differentiate. And indeed, tirzepatide is a GLP-GIP co-agonist, and what it does is it works at the level of adipose tissue, at the level of the stomach, at the level of the brain, and indeed what it does is actually translates into improved incretin action, which is reduction of insulin and a plateauing of glucagon, increase of insulin and a plateauing of glucagon. The structure is very similar to GIP. It does not have that much of analogy to the GLP-1 like the GLP-1 RA that we know usually. It works for about 5 days, so making it convenient to use once in a week. And also you do not need to change any dose for liver or kidney disease. So this is about the pharmacokinetics of this drug. This has been studied in a huge program with multiple patients. It's SURPASS 1, 2, 3, and 4, and 5. Now, this, as you will see, is according to the spectrum of diabetes. From early diabetes, where you have people with a duration of diabetes of only 4 years, you move on to people having later diabetes with about 8 years or 9 years. And then when they are starting insulin, you've compared it with insulin degludec or with insulin glargine with multiple oral medications. And also as an add-on to insulin, which is the SURPASS 5 data. And all these things are with or without metformin. So what kind of HbA1c reduction do we see with this? Tremendous. I would in fact go on to say stupendous. Even if you compare it with insulin, which to us has been the gold standard for reduction of HbA1c, you can see with uptitrated dose of degludec and insulin, you're getting a HbA1c reduction of roughly about 1.4%. But with tirzepatide, even at the lowest possible dose, you're getting a HbA1c reduction to the tune of 2%. And 0.6%, ladies and gentlemen, you will all agree with me, is a huge change in glycemic control as far as glycemia is concerned. So across the board, whether you look at early stage of diabetes where it is compared to placebo, 5 milligram will cause almost 2% HbA1c reduction. 10 milligram will cause around the same, and in fact, more than 2% HbA1c reduction will be seen early on in the disease if you use tirzepatide versus placebo. What is interesting to note is that you get similar kind of HbA1c reduction when you even later on in diabetes, as seen in patients who were on degludec or insulin glargine or as an add-on to insulin glargine. So across the board, you're getting a good control of glycemia. And indeed, what is the real nail in the coffin, I feel, is with diabetes doses of semaglutide, it seems to be superior. Even 5 milligrams of tirzepatide is superior to the full dose of 1 milligram semaglutide, statistically significantly so when you use it in patients with diabetes. The weight loss has been also consistent across studies, and this is massive. As you can see, there's about a 7 kilogram, a 7.5 kilogram, and a 10 kilogram weight loss if you compare it with placebo. Now, if you look at the other studies that have been done with other molecules like, say, semaglutide, you've never seen this kind of a weight loss. This is massive. Similarly, across the board, you see that, of course, as you would expect with insulin, there is a weight gain. But even when you compare it with semaglutide, there is a statistically significant reduction of body weight, even with the lowest used dose of tirzepatide, which is 5 milligram. And of course, with the 10 milligram and the 15 milligram, this reduction of body weight becomes even more robust. So this was independent of BMI. And if you look at this study, in patients who were having tirzepatide and had a BMI of less than 27, you see a similar weight loss that you would see in patients who have a BMI of more than 27. Naturally, higher you are, greater is the fall. So people who are more obese will lose more weight. People who are less obese have the potential to lose less weight. But what remains constant is they will lose weight. And this is to the tune of about 10%. This is a massive improvement on what other molecules have showed in the past. Now, I think the focus that we have to have today is to look at the comparison between tirzepatide and semaglutide. Till now, I'm sure all of you would say that the most powerful GLP-1 RA that we have had has been semaglutide. And semaglutide causes very good glycemic control. Semaglutide leads to significant weight loss. Now let us look at this trial of semaglutide 1 milligram injectable per week versus 5 milligrams of tirzepatide, 10 milligrams of tirzepatide, and 15 milligrams. This is in add-on to metformin. Now, as you see, with this drug, the run-in period is very slow. With semaglutide, you need 8 weeks to get to full dose. 0.25 for 4 weeks, 0.5 for another 4 weeks, and then you're at full dose at 8 weeks. With tirzepatide, it takes longer because you start from 2.5 for 1 month, then 5 for another month, then 7.5, then 10, then 12.5 to 15. The thought that I have as far as this is concerned is, up titrating to 15 milligram might be a very good idea for superbly obese people. But in our Indian context, where though we are obese, we do not have that level of obesity where we need to go up to such high doses. Maybe 5 milligram will be enough for us. And what does 5 milligram do? Let us look at the data. So we look at the HbA1c reductions versus 1 milligram of semaglutide. 2% reduction with 5 milligrams, 2.4% reduction with 10 milligrams, and 2.5 milligram reduction, percent reduction with 15 milligrams. I would stick to just 5 milligrams because even 5 milligrams is statistically significantly more powerful than semaglutide 1 milligram, which is the full dose of semaglutide. So all 3 doses led to superior HbA1c reduction, and this was sustained. As you can see, it's almost the same when it starts off, and then it kind of has the same kind of effect at about 12 weeks, and from 12 weeks onwards, tirzepatide just takes off. And there is a massive HbA1c reduction going down from a starting point of 8.5 to as low as 5.82. I do not think till now we have seen this level of HbA1c from any molecule, even insulin. Significantly more patients achieved HbA1c of less than 7%, less than 6.5%, and less than 5.7%. And 5.7% comes into play because indeed what you're looking at is if you get it below 5.7, you're actually looking at converting the patient into a non-diabetic, which is also something that we are considering at this point of time with so much of interplay and so much of thoughts about remission of diabetes. Again, if you look at this, Look at the numbers. 90% of your people will get HbA1c of 7%. I do not think any trial in the past has shown this kind of effect on HbA1c reduction. So if you put tirzepatide on 10 people, 9 people will get to an HbA1c of less than 7%. Similarly, if you have a target of 6.5, which I think most of us these days try and avoid, you will get around 75 to 85% reduction of HbA to reach that target. And even if you're looking at converting them to a non-diabetic state, really low blood glucose, at that point of time, you are getting about 50% managing to reach that, where in comparison, semaglutide lags behind. So there is definite superiority of HbA1c reduction in tirzepatide versus semaglutide. Now, this is irrespective of baseline HbA1c, whether the HbA1c is more than 8.5 or whether the baseline HbA1c is more than 8.5. Every dose of tirzepatide effectively lowered the HbA1c irrespective of the baseline of 8.5 or more. Now, it is significantly more than what you see with semaglutide. Naturally, the higher the HbA1c, greater is the fall. And indeed, if you have people with the HbA1c of more than 8.5%, you get about a 3.5% reduction of HbA1c across the whole spectrum of tirzepatide usage. Weight reduction is also superior. You get 6.2 kilograms weight reduction with semaglutide. This is the mean body weight reduction. With 5 milligrams, you get 7.8 milligrams. With 10 milligrams, you get 10.3 kilograms reduction, and 12.4 with 15 milligrams of tirzepatide. So all three doses are statistically significantly superior to semaglutide. And this is sustained over a period of time. This is, of course, a very short study, in my opinion, just 40 weeks. But you see that the weight reduction is maintained and continues to. If you follow the track of this slide, you find that they're still going down when you're reaching 40 weeks. So you continue to maintain the body weight reduction. More patients achieve the loss of 5%, 10%, and 15%. In fact, 9 out of 10 of your patients will get 5% body weight reduction. So from 80 to 76, not a small amount, about 65 to 50%. So 5 out of 10 of your patients will get to a weight reduction of 10%. So 80 to 72, massive. And if you're looking at even more than that, 15%, 4 out of 10 will reduce the body weight in the maximum dose of tirzepatide. So with this, you find that more patients will achieve the composite endpoint of less than 6.5% HbA1c, weight loss greater than 10%, and no clinically significant hypoglycemia. So with 5 milligrams, 32% will achieve this. With 10 milligram, 50%. So half the patient population that you start. And 60% with 15 milligram. Whereas only 22% will attain this with semaglutide 1 milligram in the maximum dose. Additional measures, and I think Dr. Shukla brought in this concept very beautifully when he alluded to lipid lowering. You find that there is a reduction of triglyceride to the tune of about 25% with usage of tirzepatide in the full dose, compared to about 12% with injectable semaglutide, and waist circumference reduction of 6.9 centimeters with the lowest dose and 9.9 centimeters with the highest dose of tirzepatide. Now, 9.9 centimeters is almost 6 inches reduction in the waist circumference. You're wearing a size 40, you're suddenly size 34. It's that level of reduction of body weight. Of course, I think I have been able to prove to you by now that this drug is simply marvelously efficacious. But the next question that comes into play naturally is, if you have an efficacious drug, is it safe? And of course, we will be looking at the safety data, and the safety data shows that it has comparable side effects to GLP-1 receptor agonists, which to me is a little bit of a surprise because it has much lesser effect on the GLP-1 than you would see with the semaglutide. But yes, the side effect profile is similar. No difference in nausea, diarrhea, vomiting, dyspepsia, constipation, or any other side effect. But the good news is this incidence of nausea, which is the most vexing problem that you see in patients who are on GLP or GIP, is temporary. Of course, it's a torrid time for the patients initially who suffer from nausea, and this time you have to support the patient with various measures as well as using drugs to try and help them overcome the nausea. But the good news is over a month or so, you will find that this starts to decrease, and even with a high dose of tirzepatide, it seems to be getting better within the first 2-3 months. Hypoglycemia is not really seen. There is no really any increased risk of hypoglycemia with semaglutide or with tirzepatide. So to conclude, SURPASS-2 has shown that tirzepatide, a GIP-GLP-1 receptor agonist, is superior and clinically more significant in reducing glycemia, body weight. More patients achieved normoglycemia, and this had a low risk of hypoglycemia with faster time to glycemic and weight loss targets compared to the full dose of semaglutide. So this is really a new kid in the block, which is going to revolutionize diabetes treatment, I hope. And the phase 3 trials, to summarize, that this is the first of the GLP-GIP which is available. It is the only one, I think, as of now. It produces HbA1c reduction of about 2.6, which is even more than basal bolus insulin. But of course, you have to remember basal bolus insulin will make you put on weight as well as give you hypoglycemia. And a weight loss of about 14%, which is to the tune of 12.9 kilograms in patients with type 2 diabetes. Thank you very much, ladies and gentlemen, for listening to me.